are so honored to have Dr. Grunwald with us here today. And with that, I'm going to go ahead and stop sharing my screen and we'll jump into some questions.
Thanks for having me, Dalton. It's a pleasure to be here.
Of course, we are thrilled to have you. All right, so starting off, um, first question is actually going to be focused on interferon. So this person is asking, are doctors or researchers doing anything to show that earlier use of interferon can prevent or slow progression? Specifically, they're asking if so that with the hopes of insurance companies seeing the data to allow coverage, but really just looking at that interferon and progression work being done.
Yeah, there's been a lot of work done in interferons in really all of the classical Philadelphia chromosome negative MPNs, ET, PV, and myelofibrosis. The only one that right this second in the United States has an approval is ropeg interferon for the treatment of polycythemia vera. But before that, we used to borrow other interferons, including pegylated interferon, to treat all of these diseases. And I do think that there is efficacy in ET, PV, and myelofibrosis with these various types of interferons. One of the pieces of evidence that leads us to believe that interferons might control disease progression is that there are many patients who will have reductions in their amount in the amount of their mutation, or what we call the variant allele frequency, while they're on interferon therapy. So, for example, a patient with PV who has a JAK2 mutation, usually the V617F mutation, that's the most common type, a patient may see significant reduction over time in the amount of that mutation while on interferons. And this has been shown most recently with ropeg interferon, where many patients had a decrease in their amount of the mutation, and even some patients will become undetectable. On top of that, we can see the same thing with other mutations that characterize MPNs. Right now, something I'm excited about is in low risk, so early myelofibrosis, there is a randomized study looking at ropeg interferon compared to a placebo injection in patients who are pretty early on with their myelofibrosis. And part of that is to see, is it good to start this drug early in the course of myelofibrosis? And I think the same thing is true in ET and PV. And we will see in our guidelines, the NCCN guidelines, interferons are a therapy option for patients with ET and PV.
Awesome. Next up is, are there any side effects to long-term use of hydroxyurea? And are there any better alternatives to using hydroxyurea to lower red blood cell and platelets?
Yeah, so there are alternatives, first of all, and we can certainly discuss those. The biggest long-term risk that I think about is skin cancer. So hydroxyurea predisposes individuals to get squamous cell carcinomas and basal cell carcinomas. Usually, these can be identified early by a dermatologist who's watching a patient and doing full skin exams, and they can be addressed either with topical medicines or excision or freezing. So these types of skin cancers are not always the end of the world for patients, although they can, in rare cases, become significant. Over time, though, if a patient develops a lot of these, it can be quite a nuisance. And again, in rare cases, they can be life-threatening, but those are pretty rare cases. For melanoma, which is the most deadly type of skin cancer, there does not seem to be a signal with hydroxyurea causing that. In terms of other long-term side effects, I don't really think so. There is this controversial idea that had been out there decades ago that being on hydroxyurea for a long time might promote the risk of disease progression to a more advanced type of blood cancer. The best evidence we have, which granted is not perfect, but the best evidence we have, in my opinion, tells us that this is probably not the case, that the hydroxyurea is probably not promoting disease progression. And then alternatives kind of depends on the disease. The main two diseases for which hydroxyurea is used within the MPNs are ET and PV. For ET, the best alternatives are the interferons. Anagrelide offers another alternative, and then there are some off-label type therapies that can be given as well. For PV, we have a little bit more in the way of alternatives. We have the interferons. We have ruxolitinib, the JAK inhibitor that is used frequently in the treatment of myelofibrosis as well. And then we have a new mechanism that is being explored. We have this idea of creating molecules that look like hepcidin or that or by giving therapies that increase the amount of hepcidin, which is an iron regulator in the body. And if we can increase the amount of hepcidin or create something that mimics hepcidin, we might be able to control the hematocrit better in PV. So we have more alternatives coming, even though we already have some good ones for hydroxyurea. And then in ET, I should mention, we do also have some alternatives under study. In addition to the interferons, we have a drug called bomedemstat that's in a phase 3 study now, trying to see whether it can perform well in comparison to hydroxyurea.
Always nice to hear about things that are coming. So thanks for sharing that. I'm going to jump over to a question that comes from the chat that this individual is asking, is there any indication that gene editing therapy could help with PV due to the JAK2 mutation?
Yeah, I'm not aware of any studies that have been performed in this area. It stands to reason for most types of cancer that are caused by a mutation that if we could replace that mutation or neutralize it in a way that we would have good success. It's hard though to get to all of the cells in the body. It's hard to reach everywhere with a gene editing technique. And this is where sometimes a therapy that either is a bone marrow transplant or that is similar to a bone marrow transplant could be helpful for patients. We kind of want to erase all of the bad genes and just put in new good ones into the body. But a bone marrow transplant is a pretty aggressive therapy. We generally think, for at least among the three classical Philadelphia chromosome negative MPNs, ET, PV, and myelofibrosis, we tend to think that myelofibrosis is the only one of those diseases that's severe enough to warrant the risks of that aggressive procedure. I could imagine there comes a day where we get so good at replacing old bone marrow with new bone marrow and new gene edited bone marrow, let's say, that the toxicity of the therapy goes down where it might be warranted to give a therapy like that to lower risk diseases. I think right now, because chemotherapy, heavy duty chemotherapy is involved, and then some additional risks of the gene editing itself is involved, I think it probably doesn't make sense for some of these diseases that are at the lower end of the risk spectrum.
That makes a lot of sense. And then next up is what is the current first line treatment guidance for polycythemia vera when hematocrit goes above 45?
So we have a little bit of a risk adapted approach. So lower risk PV patients are patients who are under the age of 60 and they have no history of thrombosis, which means no history of blood clots, whether those blood clots are in the legs, the lungs, the heart, the brain, no history of blood clots. Lower risk patients, we definitely want to have them on aspirin, and we definitely want to lower the hematocrit to less than 45 with therapeutic phlebotomy, which is, some of you might be familiar with on the call. It sounds archaic, but it's removal of blood and throwing it out. That's therapeutic phlebotomy. And then if patients have symptoms or if it's hard to control the blood count with hematocrit, then there can be an indication to start a cytoreductive therapy, to start a treatment on top of the aspirin and phlebotomy. And the main treatments I already went through a little bit: hydroxyurea, interferons, ruxolitinib, and we think we might soon get some therapies in the hepcidin mimetic family. And then if I think about high risk patients, these are patients who either are over the age of 60 or they have a history of blood clots or they have both. And guidelines say that those patients, in addition to immediately getting the blood count below 45, hematocrit below 45% with therapeutic phlebotomy and starting aspirin, those patients really should be on a therapy to lower their hematocrit. And it's not really optional. Those patients should be on something, hydroxyurea, interferons, or ruxolitinib. And right now, hydroxyurea and interferons fit into the frontline part of the paradigm. And then ruxolitinib is for patients who are refractory or intolerant to hydroxyurea.
All right. Next up on our list of questions, and if people see me looking off to the side, I'm looking at a list of questions over here. But is please provide a description of the side effect of itching. Just any information that you have about what causes that itching.
Yeah. So we see itching in MPNs. In my experience, it's disproportionately in patients who have JAK2 mutations. So it can occur in ET, where we see the JAK2 mutation about 60% of the time, PV, where it's almost 100% of the patients have a JAK2 mutation, and then myelofibrosis, where again, it might be about 60% of the patients have a JAK2 mutation. And we think that it's really cytokine driven. We think that there's something about the disease that is increasing inflammation, increasing cytokines, that's changing the nerve endings and skin in a way that causes the itching. I'm not sure about every step along the way, but I have had a lot of patients who've started on JAK inhibitor therapy for their PV or myelofibrosis where the itching either went away completely or got significantly better. I do have some patients who have itching who don't have JAK2 mutations, but I find that that's rarer. I think that it's much more common in the patients who have JAK2 mutations.
Right. And then I'm going to jump back over to the chat here because this relates to a few questions that we had pre-submitted. But are there any other medications available for myelofibrosis besides Jakafi that do not cause such anemia? This individual is not eligible for a bone marrow transplant. But could you kind of cover the four different JAK inhibitors and why the different use cases for each?
Yeah, so we have ruxolitinib we've had since 2011. So it's been before that, we really didn't have many therapies for myelofibrosis, and now we've had it for about 15 years. And it's very good at reducing symptoms for most patients. It also can reduce the spleen size in patients who have large spleens. It is the frontline therapy of choice for most patients, most providers involved with myelofibrosis. It does have a side effect that you mentioned, which is it can make a patient more anemic. It can also increase thrombocythemia or low platelet counts. And these are especially problems if the hemoglobin, the red blood cells, were not that robust to begin with, and if the platelets weren't that robust to begin with. And so we do have some options for patients with those problems, and the array of options is increasing. Fedratinib was the second inhibitor approved. I think it was approved in 2019, second JAK inhibitor approved, kind of around 2019, 2020. And it has some of the same issues that ruxolitinib does. It's also a pretty strong JAK inhibitor. It can reduce the spleen size. It can reduce symptoms. There was a concern early on that some still have that it could deplete the amount of thiamine, which is a vitamin. It's one of the B vitamins in the body, and that depleting thiamine is not good for the nerves. So there were some patients early on who had some nervous system side effects. It's a little bit less of a concern now, but we do measure that vitamin thiamine, and we can give the vitamin preventatively to make sure patients don't get low in it. But when I said that fedratinib has the same problems, it can cause anemia, it can cause thrombocytopenia, usually not major, but if you're starting off pretty low and then you get one of these medicines, ruxolitinib or fedratinib, it could take you down to the point where suddenly you're needing more therapies to bring up your red blood cells, bring up your platelets, maybe transfusions even. Now, getting onto the newer ones, in 2022, we got pacritinib. Pacritinib is approved for myelofibrosis patients with platelet counts less than 50. There's been some research that's shown that pacritinib inhibits this it inhibits this protein called ACVR1, and by doing so, that seems to help anemia. And so there are patients on pacritinib whose hemoglobin goes up, and there are some whose hemoglobin stabilizes. There also are invariably going to be some where the hemoglobin goes down, but that medicine is not thought to be as hard on the hemoglobin as the first two JAK inhibitors. And even some patients become transfusion independent. So if somebody's starting off on transfusions for myelofibrosis related anemia, there are patients who take pacritinib where the anemia improves over time. That is something that we can see in a subset of patients. And then finally, the newest JAK inhibitor approved, which was 2023, momelotinib, that one is approved for myelofibrosis patients with anemia. It's sort of a specific anemia related drug. It's once a day. And there are patients who had hemoglobin improvements on studies with momelotinib. And also, there are patients who started off transfusion dependent who became transfusion independent on the drug. Now, there's also a strategy called an add-on strategy. Rather than just taking one drug, a JAK inhibitor for this disease, myelofibrosis, we could say, okay, somebody's ruxolitinib's working pretty well, or whichever one they're on is working pretty well. Can we add something onto the therapy to try to make the hemoglobin better? And the three things that I've seen pretty frequently added are erythropoiesis stimulating agents. So there are different names for these things, but these are drugs that increase the amount of erythropoietin in the body. Erythropoietin is a hormone that the kidneys make to stimulate the bone marrow to make red blood cells. And this therapy is especially helpful in general if patients are starting off with a low erythropoietin level in the blood. The second therapy I see a bunch is luspatercept. Luspatercept is a therapy approved for MDS with or myelodysplastic syndrome with anemia, and it is a therapy that's borrowed from MDS to be used for myelofibrosis, and it works sometimes. There was recently a clinical trial trying to prove that it works, and the trial failed by just a little bit. And so I think it works for some patients and not others. It's definitely an off-label therapy that's frequently used. And then finally, danazol, which is in the androgen family of drugs. That's a pill, and it's a pill that can improve the blood counts, and it can be taken together with a JAK inhibitor. And then there are other agents that are under study in myelofibrosis to see if they can be added to JAK inhibitors to try to improve blood counts over time. So I think we have an increasing armamentarium, and it's only going to increase in the future.
Yeah, that's really good to highlight. And I think very important to highlight that a lot of these trials are underway and really trying to find ways to improve and see if there is add-on or combination therapy for JAK inhibitors. Next up, we have two questions that are related to the use of gloves while taking hydroxyurea. Is our patients recommended to use gloves when handling hydroxyurea?
The quick answer is I don't know. I think it's probably a good idea. Um, so I'm going to look that up.
All right.
So, I usually have our clinic pharmacist meet with patients to discuss some of these issues and questions. And a lot of times, the big deal with hydroxyurea is that we don't want to touch something after we touch the hydroxyurea. We don't want to touch a baby, or we don't want to touch somebody who might be breastfeeding, or
Mhm.
give a hydroxyurea exposure to somebody that we don't want to give it to. And so that's why I think gloves are usually good for chemotherapy. Now, I think an alternative would be to wash your hands afterwards. Um, but looking up here to see whether gloves are recommended. Yeah, so usually recommended. Um, I think the alternative that's presented is hand washing afterwards, soap and water. I think if you're handling hydroxyurea for somebody else, this just kind of came to me that if a spouse or a child or parent is handling hydroxyurea for somebody or friend, then the person who's not taking it probably would want to wear gloves so that they're not exposed to the drug.
Of course, always better to be safe than sorry.
Yeah, so I think a good idea, but if it's just the patient himself or herself administering the drug, I think good hand washing could be used instead.
Okay. And then next up, I'm jumping back over to a pre-submitted question here. That is, do you know if it is okay to take vitamin K2 for bone health if you have either essential thrombocythemia or PV, or do you know of any work that may have gone into that?
Yeah, this has come up a few times in clinic. It's kind of something that I think is increasing recently. I don't know if primary care providers are recommending K2 or if patients are doing it on their own, but I'm getting this sort of question in clinic. And what we've come up with in conjunction with our pharmacists here is that there are some formulations of K2, and oftentimes it's in combination with vitamin D, which is good for the bones too. There's some formulations that we realized have very, very high doses of K2 that are so high that they might be bad for somebody. And so we've checked the amount of K2 in patient supplements. And if it's a low amount of K2 with or without vitamin D3, we usually say it's okay to take. If it gets into the what we think is a way supraphysiologic, so way more than anybody's body would ever need amount of K2, then we say you might want to tone it down to kind of the amount that a body would need. And I don't know the exact numbers off of the top of my head. I'm pretty reliant on our pharmacists in the clinic where we work together and we look this up. And we also ask patients to take pictures of their bottles so we know how much of everything is in their supplements. And we try to make a recommendation. Now, I would say that I'm not sure that there's something special about taking K2 in patients with MPN. I don't think it's well studied enough that we don't sort of in a forward way recommend for patients to be on K2. But if patients come to me with the question, we just try to make sure they're not on a potentially dangerous dose of it.
Okay. And then this question, I'm actually going to kind of turn this into a two-part question. Um, so part number one is, do you know if this individual is exploring the idea of using medical marijuana for anxiety? They have ET, because they're looking for some guidance of if that could potentially be safe. And then part number two is pulling from a question that we got here in the um, cat and is about peptides. Um, so just kind of exploring these ideas of maybe things that aren't super well studied. How can patients go about navigating that safely?
Yeah. I think the marijuana question's been out there for quite a long time now. I don't think we've made a lot of progress in understanding it for MPNs and knowing the answers. I have a lot of patients who do take marijuana in various forms. I also get asked the question a lot, and I certainly don't recommend it, meaning that I don't recommend that patients take it because it's not proven to help. Yet at the same time, I have patients who come to me, they tell me they're on it, and they tell me that it's helping. And who am I to argue with them if it's helping? I think that it probably does help some patients. How do we be careful about it? Well, I think, trying to make sure you're getting it from a reputable source. I know medical marijuana is legal in some places, not in others. It's not legal where I am. But so it hasn't really come up in terms of prescribing it. I will say that some patients smoke it, some patients eat it, some patients use oils. There are different kind of ways to administer it. The smoking bothers me a little bit because simply of the particles going into the lungs, and I worry that there might be some lung damage independent of the drug or medicine itself. So I didn't really answer your question about the marijuana. I just don't know enough to recommend for or against it right now. But I will say that it's coming up, and I would be interested to see studies that give us a little bit more information to guide us and to help us guide patients. And then in terms of peptides, I also have to say that I don't know. I've heard a lot about this, especially in the past year or two, that this idea of peptides, and it's been separate from MPNs. It's been more in general. People trying to be healthy, people trying to be stronger and lose weight, and they're asking me about peptides, or I'm listening to the radio on the way to work or the way back on the way back from work. I was listening to a famous physician interviewed on a radio station the other day when I was driving, and he kind of summarized a lot of information about data, including peptides, and said really the data is not there yet to support the peptides, but he understands that it's big and growing industry, and folks are taking the stuff, but he thinks folks are spending money without there really being a lot of evidence that the body processes the peptides in a way that's helpful to the body. So I'm learning about that one together with you, I would say.
Yeah, definitely emerging, but maybe not around quite long enough to have a definitive answer yet. Jumping back into some of our pre-submitted questions, is the neutrophil to lymphocyte ratio relevant to MPN status and or progression?
I have to say, I don't know. I don't know. Neutrophils to lymphocytes. It's not something that I look at on a day-to-day basis. Um, Now that you mention it, I'm going to have to learn more about it and observe my patients to see if that turns out to be important. I find that the ratio is pretty high in most MPN patients because the the malignant clone tends to be in that myeloid group of cells, the cells that produce the neutrophils.
All right. And then kind of a follow-up to this one, I guess, is how does an individual know when their PV is transitioning to myelofibrosis?
Yeah, so that's something that unfortunately I know almost too much about. It's an area of study for me and also an area of clinical practice. And so to me, the most common thing is anemia. So somebody with PV who was requiring a lot of phlebotomies stops requiring phlebotomies, or they were requiring a lot of hydroxyurea or interferon or ruxolitinib to bring down the hemoglobin, and now the hemoglobin's controlled on its own, or it's just getting frankly low, where instead of somebody with a high hemoglobin or normal hemoglobin, we have a hemoglobin of 9, 10, which is low. That is kind of a chief indicator. Splenomegaly, so growing spleen, is a big indicator in my mind that somebody might be turning into myelofibrosis. Increasing symptoms, especially symptoms that we associate with cytokines, can be an indicator. And then leukoerythroblastosis, where we see young blood cells. They could be blasts, they could be other young white blood cells in the blood, sometimes nucleated red blood cells in the blood. That change in the peripheral blood is consistent with transforming to myelofibrosis. Lactate dehydrogenase, which is something that cells release when they're destroyed, and they're a marker of increased cell turnover, that tends to go up in myelofibrosis. And then the confirmation of somebody's transformation from PV to myelofibrosis is usually involving a bone marrow biopsy that shows more reticulin fibrosis in the marrow, usually grade 2 or 3. It's out of 3, so grade 2 or 3 is consistent with transformation from PV to myelofibrosis. And so that kind of set of signs and symptoms together, and you don't need all of those things, but a few of those findings together gets me thinking that somebody is transforming. And we do have some formal criteria to make the pathologic diagnosis of the transformation.
And then switching gears for a little bit, I have two questions that are about clinical trials. So question number one is specifically asking about the Inca 033989 um, trial, but if you have any insight for eligibility criteria, if someone is interested, how they would go about participating in that trial. And then the next one is about is there still a trial for monoclonal antibody therapy for ET?
So the second one.
Is there still a trial for monoclonal antibody
Yeah.
therapy
So
for
these are yeah,
ET?
these are two related questions. The first question is about Insight's CALR antibody. So just for those who are on the call who might not be aware, somewhere around 30 or 40% of patients with ET and myelofibrosis have a CALR mutation. And there are two main types of CALR mutations that are common, called type 1 and type 2. And one idea is that maybe we could reverse the effects of these diseases, ET or myelofibrosis, by neutralizing the CALR mutation. So there are studies that are trying to attack this mutation in patients with the mutation. And Incyte has, which is the same company that makes ruxolitinib, has developed this antibody to attack the CALR mutation. It is not intended to attack the wild type. So for patients who have normal CALR, it should not attack that CALR protein. And this is being studied in a phase 1 with expansion trial. in ET and myelofibrosis at a number of centers around the country. There is a link that I will find. I can put it in the chat here, and it will be from clinicaltrials.gov. It will show you a list of centers, probably with contact numbers, if you were interested in going to one of those centers and being considered for the study. One of the centers I know is our sister center, which is Wake Forest University here in North Carolina, about an hour and 15 minutes up the road from me. They have that trial over there. We over here, just to sort of loop into the second question, we over here have a bispecific antibody with Johnson and Johnson that's in a clinical trial. And this is also against the CALR mutation, except it's a little bit of a different strategy. It's not just an antibody to the CALR mutation. It also has this other arm that's an antibody against CD3, which is on T cells. And the idea here is that maybe we can engage the immune system, the T cells, and train the T cells to fight the CALR mutation so that the immune system is fighting the cancer in ET and myelofibrosis. And that study is still open here and elsewhere as well. So I'm excited about both. There is there have been some data shown with the Insight molecule. There have not been any data, to my knowledge, that have been publicly released about the Johnson and Johnson one yet, but online there have been some press releases that you can find showing, for example, that patients with ET who've been on this, they've tended to have a pretty good reduction in their platelet count with the Insight molecule.
Awesome. And I will also include a link for everyone in the follow-up email. But HealthTree does have a clinical trial finder where if you have your records connected, we can help kind of take some of the legwork out for you. It'll help you match two trials based on eligibility criteria because going through clinicaltrials.gov can be a bit of a pain sometimes. So it just makes it a little bit easier. So I'll include that link in as well.
Yeah, and I'll
But
try to get that the 988. So when's it? There's a question popping up about when it's going to be available on the market, and usually the way these things work right now, there's a phase 1 trial, and the phase 1 is not going to be enough, I don't think, to get the drug approved. A lot of times there has to be a comparative trial where the new drug is compared to an older standard of care, and it usually takes a few years to do that. So I think we're probably a few years away still.
all right. And then kind of sticking with CalR right now, but would a bone marrow biopsy be necessary at diagnosis if the diagnosis is made early with a blood test that shows a CalR type 1 mutation?
I tend to favor the idea of doing a bone marrow biopsy at diagnosis. Now our blood tests are becoming so good that it's tempting not to do a bone marrow biopsy. Sometimes patients don't want it because it's painful for sure to get a bone marrow biopsy. The physicians don't want them, they feel bad about telling their patients to get a bone marrow biopsy. But if you look at any set of guidelines for MPNs, it says that part of the diagnosis is getting a bone marrow biopsy, and then part of the diagnostic criteria for each disease, ET, PV, myelofibrosis, it involves looking at the bone marrow biopsy. Now, what's the reason for that? Well, sometimes somebody might have a high platelet count and they might already have myelofibrosis, but it might not be showing yet in the blood. You might need the bone marrow to show that it's myelofibrosis, and that would give some lead time because eventually it would become apparent in the blood 6 months, a year, 2 years later that it was myelofibrosis. But it might be good to know early that that's what somebody has. So the blood can be a little bit misleading in distinguishing among these diseases. And then the second thing is I like to have a baseline. So if we know how the patient's disease looked on the bone marrow biopsy at the beginning, then if there are changes in how the patient's feeling or changes in the blood counts over time, we can do another bone marrow biopsy and compare it to the original and to see are there signs of progression within the bone marrow.
All right. And then I'm actually going to jump back to a question that we were discussing right before this started is there anything that you can say about MPN MDS overlap syndromes?
Yeah. So we we sometimes, to simplify things and to when we're talking about them, we talk about MPNs like they are three completely distinct diseases. We've got ET, the high platelet disease. We've got PV, the high hematocrit disease, even though we know the white count and the platelets can also be high in PV. And then we've got myelofibrosis, the scar tissue and the bone marrow disease. And in reality, the diseases aren't reading our books that we're writing or our articles, and the diseases don't have to follow the rules that physicians and scientists make for them. And a lot of times it's a little bit more fluid where a patient's disease might have features of both and it might be in between. When we talk about MDS MPN overlap, we're talking about myelodysplastic syndrome, which is a disease where a lot of times patients have low blood counts and they also have funny looking cells in their bone marrow. So they have disordered cancerous blood cell production in the bone marrow, usually not high blood counts and usually not fibrosis. And then, so a patient might have features of that disease and then also have features of an MPN. So what do we do when we have that? When we have a patient who's got features of two different diseases in the bone marrow, well, we see, does it look and act more like one or the other? And we try to individualize a patient's plan. So if a patient's disease has high blood counts and there's a lot of itching, there's a lot of night sweats, sort of the symptoms that we think of as MPNs, I might start with more of an MPN-like therapy, a therapy to lower the blood counts, control the symptoms, and so forth. If a patient's disease starts with more features of MDS, so low blood counts, sometimes a lot of blasts or leukemia cells in the bone marrow, if those are the drivers or the principal features of the disease, I tend to use therapies that are more targeted for that disease. And those would be treatments to improve anemia, like erythropoiesis stimulating agents, luspatercept. Now we have one called imetelstat for MDS. And then on top of that, for patients with more severe types of MDS, I would consider hypomethylating agents. And that's a disease type where fitter patients, healthier patients, oftentimes will need a bone marrow transplant for that MDS MPN overlap type of syndrome.
Great. And I'm just looking to combine a couple of questions here because we've got multiple questions are asking about vitamins and supplement use. There's one about should PV patients take B12 and or folic acid? Another question about vitamins, any vitamins that may help with anemia. And then we also had a pre-submitted question about any natural supplements such as um, NAC or curcumin that may help lower platelet numbers. So where does the field kind of stand when it comes to vitamins and supplement use?
Yeah. So, by the way, I found the link for the 989 study. And if you click on that, this is a publicly available website. All of you have access to it. It sounds like HealthTree has resources too that might make it easier or a little easier to navigate than the clinicaltrials.gov website. But the website that I sent the link to does have the locations and there's a phone number. There's kind of a call center for patients who might be interested in the study. And then Dalton, thanks for the question. I I think that vitamins are definitely helpful for some patients. I tend to think that vitamins are good if you're low in that thing. Like, so if somebody is deficient in vitamin B12, I tend to think they should be on vitamin B12 to normalize their levels. B12 is important for blood function. It's also important for nervous system function. So brain and nerves and spinal cord and so forth. Iron. Iron deficiency is a big issue. It's a tricky one in PV for a reason I can explain. But patients who are low in iron with myelofibrosis or with ET, I would treat with iron. If patients are not deficient, then I don't think they need it. In PV, it's tricky because phlebotomy works by lowering the iron. And so if somebody's on phlebotomy and then we give them iron at the same time, we end up in a little bit of a cycle. And I don't necessarily think that that cycle is good for patients. If a patient's on a cytoreductive therapy, whether it's hydroxyurea, interferon, ruxolitinib, or clinical trial, something to reduce the hematocrit in PV, where we're not having to do phlebotomies, I think those are patients who might tolerate some iron replacement and try to get their iron levels up to normal if they're low. And then folate, I think, is another one where if it's low, we should replace it. If it's not low, I would not. I do worry about overdoing it with vitamins in PV because B12 folate and iron could stimulate the bone marrow to make more cells than you need, which is a big problem in PV, too many red blood cells. And so then it might increase what we have to do to treat the disease. And then other supplements, you kind of mentioned a number of other ones. There are a lot of them out there. We get asked about them all the time. I hear about a new one from patients all the time. So y'all are teaching me new things, and the pharmacist and I are scrambling, and we're working with integrative oncology. We've got a team that helps us kind of figure out which supplements are safe and which ones are not. But I have to say, a lot of times we just don't know. You asked about two, NAC and curcumin, which I think curcumin and turmeric have an overlap. One is an ingredient in the other, but I sometimes forget which way around it goes. These are blood thinners, so they're agents that either thin the blood or can interfere with platelet function. I would not expect some patients take these medicines thinking that their platelet count is going to decrease. I have not seen that. I do have patients taking these supplements. I've not seen a patient's platelet count decrease in a consistent way on these supplements. But there's still this idea that maybe by decreasing the stickiness of the blood, they might decrease blood clot creation. And I think it's a good idea, meaning I think that it's something that's worthy of attention. It might work, it might not. It might also stimulate bleeding if we thin the blood too much. So I would say unproven NAC and curcumin, but not necessarily a bad idea. And I do not expect it to lower the blood counts.
Awesome. And then we are coming up on time here. So we've got about probably 5 to 7 minutes worth of questions left before we'll have to hop off. I want to get to this one because I think it's one that a lot of patients have and face is what if you're not eligible for a transplant? Just what options are available at that point?
Yeah, so I think there are various reasons somebody might not be eligible. So if somebody's got severe heart dysfunction, somebody's got severe kidney dysfunction, liver dysfunction, lung dysfunction, those might be reasons that somebody can't, or if somebody's functional status is so poor where they can't get around, where they wouldn't be able to withstand some of the side effects that come with transplant. There are patients who are not really eligible. If there's any question about eligibility, I encourage patients to get a second opinion and to learn more about transplant from multiple places rather than just going to one place and hearing that they're not a candidate. And then the other options are for ET and PV. I would say most patients don't need a transplant. In fact, I've never done a transplant or heard of a transplant for ET or PV. I imagine this question is mostly about myelofibrosis, and then for
Mhm.
fibrosis patients who can't get transplants, many of them do well with ruxolitinib. I have some patients who are almost, I've been here 13 years. I have some patients who have been my patient with myelofibrosis for more than 12 now. So, there are patients who can do very well with myelofibrosis for more than a decade, and it's probably longer than that. There are probably patients who live a normal lifespan with myelofibrosis. And then JAK inhibitors and these other supportive therapies that we were talking about. We have interferons under investigation for myelofibrosis. And then there are a lot of new drugs, new mechanisms that are being investigated. There's BET inhibition that's being investigated. There's a drug that I mentioned called imetelstat that's being investigated in myelofibrosis. It's already approved in myelodysplastic syndrome. There have been studies of a drug called selinexor. There are so many drugs in this space. I mentioned bomedemstat for ET. It's being studied in other MPNs now, and tons of drug companies involved in the space because they've seen what happened with ruxolitinib and how that became a big drug and helped a lot of patients and kind of got a lot of indications in the MPNs as well. And with that, there's been a lot of interest, and we're going to get more drugs for patients. So I do think medication therapy for those who can't get transplants, but also if your myelofibrosis is severe, would try to make sure you're really not a candidate if there's any question.
Okay. And then it's got about 4 minutes left. And if we don't get to every question, I do apologize, but I want to be cognizant of Dr. Grunwald's time here. Um, this one's really kind of a disease biology question, but what exactly causes bone marrow to get fibrosis? We know that having
Yeah,
mutation causes fibrosis, but what does the mutation do that causes the formation of the fibrosis in the bone marrow?
yeah. The the fibrosis is it starts off with the megakaryocyte. So the myelofibrosis is really cancer of these platelet precursors, which are these large cells in the bone marrow called megakaryocytes. And when they're overactive, they release these cytokines. They release a bunch of these kind of inflammatory molecules, and the inflammatory molecules tell the bone marrow cells, not the blood cells, but these are called stromal cells, cells that live inside the bone marrow, like fibroblasts. And the cytokines they signal to these stromal cells, these fibroblasts, and tell them to make more scar tissue. Um, and the scar tissue is what we call fibrosis, and it's what we see in the bone marrow when we do something called a reticulin stain. Now, there are a lot of articles about every little step on the way, and I'd have to have it in front of me to kind of walk you through it. I'd have to have a diagram of it in front of me, but it's the megakaryocytes telling the bone marrow stroma, which includes fibroblasts, to make to make scar tissue.
Okay. And then this is one that I think I scrolled past earlier, but do you know if JAK inhibitors can cause the skin to thin?
I don't know. I've not been asked that before. It would not surprise me. JAK inhibitors have been used to try to promote hair growth in some dermatologic diseases and to change skin pigmentation as well in patients with autoimmune skin diseases. And so I think it's possible. I don't have any knowledge in that area, but I know that JAK inhibitors can affect the skin, so it makes me think that it's a possibility.
Okay. And then you mentioned hair growth, and this may end up being our last question, but it's also related to hair. Um, this individual's exploring a stem cell transplant down the line potentially. They're asking, does the chemotherapy that cause hair loss also cause the hair follicles to fall out?
Okay. Oh, here, I imagine that this is about if you got a hair transplant and then bone marrow
Hmm.
transplant, would the transplanted hair grow back?
Hmm.
Um, yeah. Okay. I've never seen this. I imagine I've taken care of somebody who's had a hair transplant, but has not told me that they had a hair transplant. So I don't have this experience. I would think that there's a good chance it would grow back after the um transplant. But if you're getting like if the bone marrow transplant's scheduled, I'm not sure I'd go to get a hair transplant the day before. You might want to wait till recovery afterwards to get it. But it sounds like this question has more to do with hair transplant and then maybe needing bone marrow transplant a few years later.
Hmm.
And would the bone marrow transplant get rid of the hair follicles? And in that situation, I would think that the hair would survive because usually for a hair transplant, the plastic surgeon or dermatologist will look to kind of a donor, like a hair donor source area, whether it's kind of the sides or the neck or the upper back, and move the hair up there. And I would think that that would be like a new good hair that should be able to grow back. But I don't have experience or scientific knowledge enough, just my kind of expectations.
Awesome. And I know I said that was our last question, but I have one last one for you. But just if there's one piece of advice that you could give to MPN patients, what would you like them to know about the field right now?
I think there's so much hope. I think things are not perfect. Patients have almost all MPN patients that I know have some symptoms, some quality of life impairment, and that's been the case the entire time I've been a hematologist. When I started as a fellow, when I was training in hematology, we did not have ruxolitinib, and then we got ruxolitinib. Now things got so much better, and now we've got three other JAK inhibitors. We've got new and better interferons. We've got tons of clinical trials, and some of these new drugs and trials will be approved soon, I think. And there's so much hope for symptoms. For patients with high blood counts, we're getting new treatments to bring them down. For patients with low blood counts, we're getting treatments to bring them up. And then treatments that will shrink the spleen and improve things like itching and night sweats and so forth. So it all takes time, but we're getting more and more options, and it's made it, it's given me more hope as a provider, and I want it to be giving patients hope as well.
Well, thank you so much for your time, Dr. Grunwald. This was great, and we got through, I lost count, but I'm going to venture right around 30 questions or so. So, pretty impressive to get through that in an hour. Just thank you so much for all the work that you do and for taking the time to meet with us today.
Yeah, thanks for having me. It's been a pleasure, and I'll look forward to doing this again sometime.
Awesome. And as we are wrapping up here today, I just wanted to let everyone know that HealthTree does have a Black health community. So we are always looking to get people more involved with HealthTree and really getting people to find their comfort zone here. So we do have a dedicated Black health community. If you or anyone that you know may benefit from that, please feel free to let them know. This is open, and as always, everything is free. We just really want people to have that comfort. And we do have, I've gone ahead and highlighted 3 upcoming events um, for us that I think people in this event today might be interested in. Actually happening in about an hour or two. We have Adjusting Mentally and Emotionally to Diagnosis. So, really good mental health webinar. So, if you want to stick around and watch that one, highly recommend it. If not, you can register and get that recording sent to you as well. And then tomorrow we have a community gather event. So this is not a recorded event. It's more of a support group style, but just it's navigating the unknown of living with an MPN. So we normally have a great group of MPN patients who get together and just share experiences, and would love to have anyone join who is interested. So that'll be tomorrow at 1 p.m. Eastern. And then next Tuesday, we have Finding Strength and Serenity Through Chair Yoga for Cancer Patients. This is a really cool one that's really focused on just promoting some good physical activity. The individual leading this is actually a multiple myeloma patient. So, very tailored towards cancer patients and specifically blood cancer patients. So, really good event. If you're wanting to be a little bit more active, chair yoga is a great way to do that. So if that's something of interest, please check that one out. And then finally here, I just want to say a big thank you again to Dr. Grunwald, but also to everyone who joined or submitted questions for this event. Um, I appreciate all of you for supporting HealthTree and the work that we're doing here. And it means so much to me that you've spent part of your day with us. Please feel free to reach out to me. My email is up on screen here. I'm always happy to chat with members of the community, and I love feedback on what else we can do to really support you where you're at. Um, with that being said, I hope that everyone has a wonderful rest of your day, and I hope to see you at another event soon.